The wonderful thing is we've had amazing speakers today. And the most incredible thing that we've had today is, as amazing as everybody is from many, many different countries around the world, the message has really been the same. That's quite incredible, because I think that's kind of asynchronous communication in a way. The message is kind of getting across, it's getting towards what we're going to do. So what I'm going to share with you, the last theme of the day, is really partial extraction therapy, which is really a passion of mine. It's something I've been working on for more than 13 years, and we've published a lot of papers. And really it's about the evolution. And what I'm going to share with you today is really a story. It's a story and it's a journey. It's a journey of success, it's a journey of failure, and it's a journey, most of all, of growth. And really we're going to talk about the evolution of, the evolution of partial extraction therapy. And wherever I go, everybody tells me it's such a difficult technique, and it's so technique sensitive, and it's so, you really got to be good, and you've got to be skilled, and not everyone's got your handset and your hand skills and things like that. And I hear that so often. And the key factor is we've really come a long way over the last 14 years. This is very stretched. Okay, how you working on this? Okay, no stress. We'll carry on. I'll work on it. You work, I'll talk it. Okay. And the key factor is that what I'm going to share with you is I'm going to share with you all of the knowledge of 14 years of science skills. Because people think that this is something new, partial extraction therapy is new. It's not, it's 14 years. And not only that, is we've spent many, many years, at least the papers that I've published in my group, okay? And there are many, many more to come. And there's such a dearth of information and studies that are coming out of us. As you say, how you need a prospective study, you need a double blind. And the thing is, we have all of this. It's all there, it's all been done. And I think the key factor is not whether I'm having success. The key factor, something I teach my students all the time, is when you read a paper, whether you have a case series or whether you have anything, whatever it is in the hierarchy of what we do, the key factor is does that result in that paper resonate with you? In other words, are you getting exactly the same result, or is what you're seeing 100% different to what you're getting? When we look at our cases, when we look at our implant cases, and we look at the soft tissue, and we look at the bone, and I'll show you lower teeth, because everybody here knows lower teeth are the most difficult to do. There's not even a debate. Anyone who's done an immediate implant on a lower jaw and looks at their cases 4 and 5 years later knows that what they achieve never ever looks the same. So how do we get the soft tissue to look so phenomenal in these cases? How do we allow it to get everything to stabilize and to look? Now, no soft tissue was hurt during the making of this tooth. Okay, we didn't damage the palate in any way. We didn't cut into the palate. There's no soft tissue here that was utilized during any of this work. So if we look before and after 3 years, and we look at the result from the occlusal, from everywhere, you can see there's zero collapse in the tissue. And that's the key factor with socket shield that we're trying to get. So when we look at this, and the Christian related to this, we talk about predictability, because how often do you go to a conference and you see people show their best cases, and you look at it and you walk away from it and you think, sure, I don't really get that kind of result. Because what happens up here is we show only the best. You don't see the worst of what we achieve. We stand up here, we get paid too much, we want to... Christian does dress up. Okay, they can see them, they can see the stuff. The key factor is that I might be showing you all of my good cases. And how many good cases might I have? Christian agrees this. I might have only 14% of them. And not only that, but we publish 14% of our good cases, and we claim that as 100%. And how often I walked out of a conference thinking, I'm really a crap surgeon, thinking I cannot achieve that. And still to this day, I cannot achieve perfection in every case. It's not possible, because there's biology involved. The second thing is reproducibility. It's all very well that I can do the job. What about you? When you take the case and you try it and you fail more times than you succeed, is that a reproducible case? Is it a reproducible technique? Or maybe the person who's claiming predictability is not achieving the predictability that they're making the claim for. And that is the frustration that I have, essentially. So I show you this case, 2012, 2010, 2012, 2018, a very early immediate implant. We've been doing immediate implants for many, many years, since the 1990s. Now, you look at this case and you can actually see over the 8 years, look at the soft tissue coming down. Now, I can show you this case, and I can say to you, if you do your crown this way, if you put your soft tissue this way, if you do everything this way, you are going to get this fantastic result. So I'll ask you, how many cases do you think I have like this? Now, I've been doing this for 30 years, and I don't know it. Like that. But 30 years. How many cases do you think I have like this? Take a slide. 2 cases. So if you look at the case from the occlusal, if you look at it from the side, if you look at the emergence profile, everything's beautiful. We're not looking at the face, okay? We look at CBCT. Don't show me a periapical and claim zero bone loss, because if you're looking to stabilize bone, it's the buccal bone that's important, not the interproximal bone, because the interproximal bone is teeth dependent. I want to know that your buccal bone. So what gave you this? This was the perfect storm. Thick gingival morphotype, correct dimensional, correct 3-dimension, narrow diameter, thick buccal plate, everything that was discussed in the previous areas. Large jump gap, and that's a key factor to allow the biology of the bone to grow around. Your wide socket dimension is something that's not mentioned in enough studies. You mentioned it, Bass, you mentioned it in your thing, and let's look how important it is. Because this is the classic stuff. And I'm showing you my cases. I'm not going to show you other people's failures, because if you tell and you show other people's failures, you say, I don't fail, this is the greatest, then how do you know what you did wrong? Because you do not know what that person did. Look at your own cases, photograph your own cases, criticize your own cases, and show people your journey, not how you fix somebody else's, because that doesn't really tell you what went wrong, does it? Because you didn't know what went wrong. But this is my case. Over 4 years, you can see this is the classic scenario of immediate implants. So I ask you and I beg the question, is there bone over the buccal? Who says there's bone? Put your hand up. Thank you. With 2 people, but I'll make it 2. Thank you, 3 people. Okay, I love it. But I can take a periapical and I'll show you a beautiful bone and you'll say, whoa, what a fantastic result. But let's look at the CBCT. Yes, wow, amazing. So just because we have phenomenal bone does not mean we have phenomenal soft tissue. But how often do we see this? We take a buccal view, we show these, we don't show CBCTs, we make a claim. We've got zero bone loss. What a fantastic result. But there's still collapse. You saw we had the recession, we had everything that was there. And as you set me up absolutely perfectly, if we look at Vivian Shapir's publication with Danny Buza, and this is just one of many, many, many. There is no controversy about what happens to the buccal plate when you extract the tooth. Some people say, yes, well, no, when I extract the tooth, it doesn't happen. There are parameters, and this is one of the key factors. How thick is the buccal bone? If it's 1 millimeter, then there's a good chance that it's going to be thicker. Then there's a good chance you're not going to get the collapse, and there's a good chance that you're going to get the success that I showed you before. But do you know how many cases of the anterior have 1 millimeter thick buccal bone? Take a flyer. 100%, 10%, 20%, 19% have 1 millimeter. Other way around. You read the paper. Well done. There's many, many papers, okay? And all of them, 90% of your cases have less than 1 millimeter. Peace. 50% of your cases have less than 0.5 millimeters, which means that all of your cases are going to collapse. And you can do whatever you like. You can make your crown shape, whatever you can put, whatever you can have bleach, hyaluronic acid, do whatever you want. You can whistle Dixie. It ain't happening. Mm-hmm. These are all of my cases over the years. And what people do when they do immediate implants, if we look at the classic scenario of buccal collapse of gingival recession, People think that when you plan an immediate implant, if you do 1 or 100, you plan them all as one implant. But you cannot plan them as one implant because there's so much more. And when you start taking out more teeth, you can see, now look at 14, and I want to tell you, I have a lot of these cases, and I know that anyone who's had any experience has cases that look like this. I was in the States last week, and they were talking about FP1, extracting teeth that didn't need to be extracted. Left, right, and center. Look at my FP1, look at me. It's crazy. Yes, there are cases that can be FP1, but not every single case. You see what's going on social media. It's a sickness. It's gone crazy. This is what is the top. We show this. Fantastic. The bottom is what we then start to iron. You say, I don't get that. You ask the people, do you ever get that? No, never. Not my cases. Okay. When they told us that we couldn't do immediate implants, this is a study by Willie Wood that we showed that if we added connective tissue, okay, we saw a lot of that this morning. We saw beautiful surgery on connective tissue addition during immediate implants. And what did this do? I went home, I tried it, we got it, we added soft tissue, we placed a provisional crown. We got stunning tissue. Measured 3.5. Whoa, incredible tissue. We look at this over the long term, 5 years post-op. Okay? You can see stunning. Does that thing that's August? Does that look longer? One weekend for the angle. Is it the angle? Okay, must be the angle. Okay. But 5 years, these cases are stable. Thick gingival orphotype, placed the implant in the correct three-dimensional position, got it right for once in the old days that we didn't know, because this is an old case. My question to you is there buccal bone over the outside? Do you know? Yes? How do you know? Because there's a CDC thing to show. But if I show you periapical, you don't know. Okay, so this really took off, and this is the standard of care around the world, and you saw many stunning cases like this. But the problem is, let's look at this case, because this is exactly the same case that I did. Then I did exactly the same technique. I extracted the lateral, which had external root resorption. I did a dual zone therapy. I added bone in the bone zone. I added bone in the soft tissue zone. I added a connective tissue graft and a bit of laser crown lengthening, close laser crown lengthening in the anterior. Off she went to my partner. Boom. Amazing soft tissue. Look at that. It's even overgrown. We spoke about keloid this morning. I want to tell you something, but look at the way the soft tissue emerged from the lips. I look at that thing and I'm so proud. I'm the proud father of the brilliant minds in implantology came up with this idea, which came on from the root submergence technique, which Maurice and Henry and Blake Barber published. And this came on where they left a portion of the root behind. And what they showed is that when they leave that portion of the root behind, you actually maintain the buccal plate. So you're foxing the body into thinking that the tooth is still there. And because you fox the body into thinking that the tooth is still there, what happens? The buccal bone remains and does not collapse. So they published this in 2010 and they left it very, very much out of there. And we spent the last years and years and years to try and work out what the right parameters are for everything that we've done here. And if we look at this case, and this is from a brilliant friend of mine, Richard Forum, who's an outstanding max fact from Dallas. And if you look at that, we've looked at the parameters now from around the world. The shield length we want as long as possible. The shield height should be around bone level. We want to have adequate jump cap to allow us to be able to fill the jump gap with bone. If you speak to Herzl will tell you that you need to engage the shield. Okay? We disagree on that point. The engagement of the shield from his point of view is because when they have very, very short shields, the shield tends to overlap because there's no bone growth within the shoulders. Okay, so there's a difference in the way we think. If we look at the other ones, the other two factors is how thick should the shield should be, about 1.5 to 2 millimeters, and it should have a 2 millimeter chamfer, which will go a little bit on there. I need some water, please. Thanks. So the difficulties, we published this paper in 2018. It's the biggest cohort of this technique in 2018. Myself and Maurice published this cohort. And we looked at the difficulties of the technique, and this is really where everything, thanks very much, this is really where the problem lies. And where everybody says how this is so difficult, this is what makes it difficult. And people are right, this is not wrong, this is where we fail, this is where people make mistakes. And the difficulties, if you look at the top side there, you can see there that we leave atypical stuff behind. And we have variance on the shield length. How long is the shield? How long should it be? We can't really get this 100%. And the last part, which we published in this paper, is that we got around 12% of our cases got internal shield exposure. Okay, people jumped on this in 2018. It was like, aha, gotcha. You see, you got 20% complications. This is not a technique that you should be using. But they didn't read the data, they just read the abstract. Because all of these cases were manageable, we fixed it, they worked, and they're still going 14 years later. So the question then comes is, what is the evolution? And I'm going to take you through now the evolution. I'm going to take you through several techniques and how over the years, over the last 12 to 13 years, we've developed the technique. And the initial technique was developed by Otto Zur and Marcus Hertzler, was really when they used implant drills. Now, anyone who's drilled a tooth with an implant drill, you know that drill cannot be used again. It's dead. It's finished. It goes in the dustbin. You can't sharpen implant drills. Did you know that? Really, I'm not joking. But the key fact is, if you use implant drills, they're expensive, number one. But number two, when you start going larger, what happens? There's a lot of vibration, and with the vibration, you can actually see what happens. You can fracture the shield. And we all found this very, very quickly, okay? But lucky this fracture occurred on the lingual side, okay? And the other problem with all of these is that often when we go with wider drills, they parallel, and because they parallel, they tend to shorten the shield dramatically. So again, you can see we place everything together, we put the shielding, we did everything that we wanted to do. We made it professional, we put the professional back, we supported the tissue, we did everything that we were supposed to do, okay? And we got fantastic results. We looked at the soft tissue, we looked at the occlusal, we looked at the buccal, that's where it was. Really stable, easy, two areas that you could see. Look at where the gingival margins are, they're absolutely perfect. Look at the collapse, there's no collapse from the occlusal area. And most importantly, look at the papilla. And this is really insane. But you'll say to me, because you all know that papilla between the two teeth, what's the difference? It's the teeth that create the papilla. But this is two implants next to each other. Okay. And this is where socket shield really is insane. Okay, I'm going to show you all. Because here we saw phenomenal results. We saw fantastic results from Ricardo this morning, two centrals next to each other. And have I got centrals without socket shield that look like this? And the answer is yes, because if you've got the right dimensions and you place your implants and you've got stable, thick tissue with nice stuff, and you can add connective tissue, you can get the bone stable between two centrals. Where you cannot do this is between the central and the lateral. So keep that in mind. So let's look at technique number two. So that didn't work for us. We came along with technique number two, and we published this, myself and Maurice, we published two papers on the different technique, and really it was all about using fast drills. Now this was great because now we didn't have that vibration, we weren't using expensive drills, we were able to now section, it was much easier, it was a much more predictable result from that point of view. And we were able to really take things out and get really amazing results 8 years post-op, stable tissue, stable buccal bone. And if you look at the CDCT, what do you notice 8 years post-op? Bundle bone. It's still there. There's no collapse of the buccal dimension. And we understand this because Hertzler and Zur did volumetric analysis. And there's 4 or 5 volumetric analysis tests that have now been done up to 5 years, 6 years, when we know that there's no collapse of the buccal dimension. If we look into proximally, you can also see it goes into proximally. The problem with this technique was that using this drill, how did you get to the apex? So this is where people struggle. How do you hit the apex? How do you make sure that you get, I can take x-rays as I'm going along, but I can't keep taking CTs to check and see that I'm going back. I think, I don't know what your rules are for CT is like 1 per patient. In South Africa, we can illuminate our patients a little bit more. Right, man. Laws are just a suggestion. Okay. But this is a real problem because now we're looking at the fact, am I hitting the buccal plates? Am I creating a shield that's too short? Am I taking out the apical portion? All of these things are still a problem. So we came up with a new technique. We published the 10-year change. And this was technique number 3, was the 10-year change. We published this technique. And here you can see with this technique what we did, we had an implant. Now I want you to take a look at this case because this is central lateral. Okay? The lateral is already there. So let's look at what we've got. You know that if you take this tooth out, that bone is going to collapse to the most apical portion. That pupil is gone. Thank God we have pink porcelain. Okay? Thank God we have this. You can see the external root resorption in this case. Luckily, the external root resorptions on the palatal lobe and the buccal, so it still enabled us to do. So people often ask, can you? The answer is yes, depending on where it is. Okay? So how do we manage this? So the technique that we developed to do this was really that we cut off the tooth. You can see here, I'm just going to go through this quickly. And you can see here, we saw this a little bit earlier, the measurement of everything that we needed. This is from the January in 2008, where they did the retraction of the lips, which allowed us, and we spoke about this, it was a landmark paper, which allowed us to utilize by the CBCT, and there's new studies that are coming out, and we've published a couple of them. We've got one new one coming soon. We are doing this, it's coming soon, okay, with gully smiles. And here, this allows you now to plan everything because now you can use your buccal gingiva as a measure. So your buccal gingival margin now becomes a measuring device for you so that you know exactly how deep to drill. Okay? But how do we find the trajectory of the canal? Because that's the key factor. And the key factor here, after cutting the tooth down, is we use Gates-Glynn to create the trajectory. So what does that do? A Gates-Glynn, as you know, is non-end cutting, so it can't take its own path. It can only go down the path of the canal as long as the canal is open. Okay, and that's called key count, so okay, the limitation. But here you can see by adding it allows us to take out the gutted perco. We've now got access to the apex. I now know exactly where to put my drill, and I can put my drill down to the apex. I can take a periapical and know that I'm at the right point. And now by working slowly up the one side, slowly up the second side, I am much more predictable at taking out the apex, removing the gutted perco, making sure there's no apex, and taking out the erect 3D position, leaving a space. Okay? Using the buccal gingiva as our reference to the depth of the implant. Okay? We pack it with bone, we fabricate our provisional, like each person has their own way of fabricating their provisional. I love using the patient's own provisional, call it a walkout as a walk-in. We put it back in, I'll explain the pencil mark in a second. And the key fact is, you can see how they walk out. And a year later, look at the buccal palatal dimension. Okay, because that's one of the key factors. The first thing is the buccal palatal dimension. 1 year later. And look at the periapical on the next. Okay, and look at the space between the shield and the bone on the left-hand side, and look at the interproximal area, and look, 1 year later, what do you see? You see bone, which was not there 1 year before. And more importantly, look at the interproximal bone. Can you see that there's no loss of interproximal bone? So when we go to the final, look at the interproximal papilla between the central and the lateral. Can you achieve this with any other technique? Not a chance. Not a chance. You can try as much as you can. We had a discussion at EAE this year, myself, Mr. Kelly, Joe Khan. So Kelly says he would much rather, he doesn't want to do this, he'd much rather run the pillar do 3 operations on the patient. I'm like, you're not doing it on my mentor or my child, not for any money in the world, as good as you are. To me, he was saying, that's all biological. To me, this is biological. If this fails, I can always build the pillar. I'm Sir Kelly's hand, but we can try and build that and go through the phases. So this comes to the fourth one. And the fourth one really is how we hit the apex predictably, because how often do we have variable root positioning, sclerosed canals, cemented the canals that doesn't allow us to get down? It happens more than you think. Okay, more than 40-50% of the time with root canal treatments, we've got this timing scenario in there. And this is where the Gates tin now falls apart. This whole technique, which we thought was absolutely fantastic, it dies. And this is where guided surgery, and as we showed it, okay, this is where guided socket shield really has made a massive difference to everything that we do. Okay, and this is now the be-all and end-all. We don't waste our time with Gates tip. Everything now is guided. So we utilize whatever technology you want. You have 2 guides. One goes to the apex of the tooth to guide you to hit the apex spot on with the drills. The second one is your implant placement. And here you can see how we go through with perfection of the new drills that we've developed to actually hit the apex time after time after time. And this has really been a game changer for us in everything that we do to give us the predictability and allow us to create what we do. So here I'll show you a case that I did with our partner, Mark Bowes, and you can see how good I'll show you a lower, because this is the most difficult area to go. It's not a central where you've got lots of space. It's a lower. It's impossible. So we did a socket shield. We did next door a cantilever with a Pontic shield where we just kept the shield. We didn't put an implant in. Why we did a Pontic shield? Because there was apical pathology. Okay. We put everything in. We got guided everything. We got everything to the apex perfectly. All right, and that was the key. Now, the whole thing about guided is that you don't have to manage the apex anymore, because those drills manage the apex. You don't need to shorten those in any way at all anymore. And allows us then to go for guided socket shield, guided implant placement. Everything's placed. Connective tissue graft to cover the the Pontic shield area. Custom healing abutments to maintain and stabilize the tissue. We never, ever use round abutments, ever. Okay, we always stabilize in the soft tissue, either with a provisional crown or a custom abutment, depending on whether you get primary stability. If you have primary stability, a crown. If you don't, custom abutment. And here you can see marked in the final crowns. And what's always important, and what I'm always looking at is lower anterior is attached gingiva, because that's the first thing to go in the lower. The minute you extract a tooth, within 6 to 8 months, that attached gingiva has shrunk. And with socket shield, you maintain that 100%. And there you can see the cantilever bridge achieved in that result. The fifth technique is the management of apical areas, because what happens in cases, okay, is we have apical pathology. Can we still do socket shield with his apical pathology? And the answer is definitively yes. Can we do immediate implants? The answer is definitively yes. One of the key factors, though, with apical pathology is it takes away your bone that gives you your primary stability. If you have enough bone, then you can. If you can't, you have to delay it. So when you look at this case, okay, the patient fractured this off. You can see he came in with a provisional. There's an apex, and you can see there's also an angulation. So if I use guided socket shield with the angulation, am I going to hit it with the angulation? The chances are not. So what we do here under microscope is we prepare the top. We do the same technique for doing the top, and then we do the discectomy approach via Vista technique. Some people open bigger flaps. We obviously work with microsurgery. I work with the microscope so we can keep things as small as possible, and we then end up taking out the oyster, and you canteen up from there. Place the implant, do your bone on the apical area. Place your implant. This one had enough primary stability. Temporary crown went in. dual zone therapy, and 3 years post-op, that is what we achieved. And if you look at the soft tissue, again, no connective tissue graft. Okay, if I have an implant next door that needs to be placed, the pin is going to be stable, even if I don't do it. I was teaching it today, saying, yes, but then you must not even do it with the 2 implants next to each other. When it's 2 implants next to each other. Especially with all on 4 going around, that disease, all on 4. Okay? You don't learn it. The funny thing is, this guy was sitting next to me on the plane in Dubai. She's fine. Yeah, absolutely. Okay, but that's what you can achieve, that beauty, that harmony of soft tissue to crown, which I have never been able to achieve as predictably as I can utilizing this technique. If we look at the periapicals, you can see stable bone. If you look at the buccal, you can see again we're maintaining the bundle bone, and not only that, but also you can see the apical healing of this area with normal GBR techniques. So everything's possible. The 6th technique is really, or not the technique, but the 6th thing that's really important is the management of the emergence profile. And this has been spoken about a lot today, so I'm not going to go into it in detail, but there is no doubt. We published this paper in 2018, prosthetic space, Maurice and myself. We published it and we spoke about the fact that we have to put the shield to bone level. And we also have to create the chamfer, okay, that you see in this area. You can see the chamfer that it creates. And that chamfer is critically important to be able to have the space between your shield and your implant and your abutment, so that soft tissue grows in, because this was one of the biggest reasons that you got internal shield exposure. We've just done a recent prospective study. We just published about a month ago where we've eliminated this completely. In 20 cases, no internal shield exposure. Okay, which happens very, very quickly. There are a multitude of papers, and all of these papers have been spoken about today. Sue, I think, was the front runner with the subcritical contour. Stavros Steranakos 2017, and Stavros has also published a brand new paper last year which goes into much more detail about angulations. Ramon was made at Mark's Blacks on the aesthetic biological concept, which a lot of people spoke about, which really is exactly what we are talking about. And this is the key to be able to have a much thicker soft tissue and allowing everything to be at the right level. So we'll go through this. I'm going to take you through this case. Here you can see the external retrosorption. Buccal roots is retained in position. We do guided socket shield, guided implant placement, put everything into the right positions. We still do dual zone therapy, so you'll notice we are still adding bone, okay, to that area there. Okay, we are still adding bone to the soft tissue zone, exactly as Dennis Tarnow and Stephen Shinu wrote in their papers. Okay. We create and we fabricate, and we use the patient's own crowns, and they walk out exactly the same way. But this is the key factor that I want to point out. This is the pencil mark that we use. Okay? And the key factor now is, what's the pencil mark do? The pencil mark is giving me the distance, the aesthetic biological contour. It's telling me where my gingival margin is. So when I take this out, okay, I will know that I haven't built enough. So if I leave this where it is, because that's not the gingival margin, my free gingival margin is going to collapse. It needs to be supported. So remember from Sue's publication, the critical contour starts 1 millimeter below the gum. Okay, we spoke, Alessandro spoke about that this morning. So we need to add on an extra little bit. We can add it on with whatever you want to do. You can use whatever technique, but now we've created that, we've increased that, so we can stabilize that thin little bit of gingiva. This is important. It's an important detail that can just cause that area just to collapse in. So it requires that stability that allows you to give you exactly what you want. And there you can see the concept of the aesthetic, the EPC, the aesthetic biological contour from Ramon almost made up. And that now, when it goes in to the area, you can see as it goes in, it supports that tissue. Okay. And you can see then, when everything's done and dusted, Beautiful soft tissue. Beautiful stability in the tissue. One procedure, one site, everything cares. If we look at everything from a periapical point of view, from a bowel point of view, we've got everything that we're looking for, the right length, the right shape, we've got the shield at the right height, everything is absolutely perfect. Bundle bone is still intact. That's what we're looking to do. We're looking to maintain and achieve. I finish off this because this is something that really has become the norm. And I normally have to give a whole speech about how important facial design is and how critical it is to everything that we do. And I'm going to show you a case of socket shield. Okay? And that case of socket shield is going to also use guided surgery. It's going to use facially designed. And this is a patient, okay? The great thing is, Christian, you gave, I don't have to give any of that. Thank you. Okay. What a master. The question comes is, I'm a periodontist. Do I need to understand the digital spine design? Do I need to understand as a surgeon the concept? I might understand the concept. I might have the dentist share it with me. And the dentist generally is the one who's in charge of this process, who says to me, Howard, you as the surgeon, please do this, 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 and this. And that's the norm. That is what we should have, because the dentist should be the person in charge. Yes? But what happens if what happens as a referral? I'm working with dentists who are very average, who do not know where things should go. When this patient, who's a great pulmonologist, she walks in and she says, listen, the dentist said you can do a special technique, so much, can you please do it because I've got this gumminess here. I fractured my tooth, I walked into the door, her story, okay? I walked into the door and the tooth is now fractured. You can see there's swelling there, so there's infection. Can I leave this? I think, what do I do? And I took one look at her as she was smiling, she's talking, we're having a discussion, and we're going through it, and I'm like, does the gum bother you? Have you ever looked at that? Because some patients don't mind the gum. Do we have to gummy scar treat every case? The answer is no. It's patient to patient. And I thought, sometimes you get so excited, we've got to fix your gums, and they get insulted. I like my smile. What's wrong with my smile? So we need to be aware of, don't get too excited. It's a question rather than we need to fix your spine. How do you feel about it? What's your, what do you feel? She says, I absolutely hate it. So I said, cool, I've got coming to mind. So we started talking about it. I started explaining the concept of altered passive eruption. I started explaining the fact that she's got a gummy smile, and we took CBCTs, we looked at the analysis, we looked at everything, we started to look at where she was, and I said, listen, there's still a lot of tooth structure underneath the gum that we could expose and take out, but we have one problem. Time's not on our side. Because normally I need to now cut the bone down and the soft tissue down. How do I do that predictably? Now, everyone says, I can do it. Of course you can do it. The key is cut and paste. Can I predictably do it every single time? That's the question. Not whether you could do it once and show the case once, and then when you were drunk the night before, as we had a lot of drunks earlier this morning, okay, where you don't get it right. And that's the key factor, because some days your best surgery is here or whatever, and some days it's here. How do you manage to get it to be as predictable? So I said to her, right, let's start the process. There you can see a fracture. It extends. We spoke about extrusion. We spoke about crown lengthening was an option. What crown lengthening exposed? The problem is that it goes interproximally at bone level, which means I have to cut away all of the interproximal bone to get it out. So that is not an option if she's not going, if orthodontic extrusion is not up for her. So we took her through the 2D. We showed her the 2D. We said this is the potential. But remember what Richard said, this is just a potential. It doesn't tell us all of the other factors that we need to look at. We need to look at everything. And we work with the Madrid Center, because the 3D is the critical. Only the 3D allows me as a surgeon to know what is possible. This dentist didn't even know that there was a gummy smile. So if we're going to do things, we're not just going to look at the gum level, we're going to look at the incisor levels, we're going to look at team positions, we're going to look at all of the factors okay, that was spoken about earlier to make sure that when she walks out, it's a wow factor, that she walks out as a brand ambassador for our. And not only that, but she also walks out as a brand ambassador for the dentist, who never even knew that it was possible. So we go through the 3D, we do everything, we get everything done, we've got everything we're able to show, we look at everything, and this is my favorite one, we look at that. We go through, this is where the gums should be in relation to the lips. Okay, so we want proportionality now, where our incisal edges are in the ideal position from a facial design, our gingival margins are in a position from a facial design. And I love this one, 0.86, 1.53, 2.29, 0.62. Does anyone have a Premier code that measures in 0.1 millimeters? All right. Not yet. Come and see me. And the second factor is this biologically acceptable? If I cut away that amount of tissue, do I know that I'm going to not cause exposure of the root? And if I cut that away, what am I going to do? Am I now going to put any margins on dentine? That's not what we're going to do. That is not biologically safe. So now we have to then look rather at orthodontics. And the patient then make a decision. Either we can cut away less so that we don't expose the immune surface, or you have to go through orthodontics, because now it's a discussion. It's communication. I see your problem, Howard. Do you want me to expose your root? No. Definitely don't want you to expose them. So I'll either accept a compromise or I will go with the 3 things that Chris spoke about. You've got a choice. Okay. So now the key factor is we have to look at this. This is a paper we did, Chris. This is the one we did together, where we started and we measured. Okay, our next one is coming up soon. We've just finished. In fact, I will finish on the plane coming through on the dummy spine wings. Okay. Now, the interesting thing when we measured dummy spines, because we measured all of these factors, okay? Knowing where the gingival margin is, knowing where the CEJ is, knowing where the bone level is in relation to your CEJ. If we look at Poseidon's classification of a dummy spine multiple eruption, how do you know when you need to do ostentopy, and how do you know when you can just get away with gingivectomy? Because we see it on social media now. You bought yourself a new laser, and now must cut come. Yes, you all see it. Have laser, must cut down. What about the bone? What about? Can't see it, it's okay. Just cut up, everything will be fine. Never mind the rebound and that sort of stuff. Okay? But this now allows us to measure that, and that's where we start looking, okay, at the perio-analysis. We start to analyze. At the paper from Vadavalis and Christian in 2014 and Christian's new paper 2022, where we started to now get a guide that now we don't have to measure the 0.52 to 0.3 millimeters. We know exactly where it is, so we're able to get that. They sent it to us in Madrid, we print it ourselves, we fit it, and we go into surgery. So here you can see now we can do everything in one go. Everything's done in one procedure, whereas before I would have had to do the crown leg thing first, then let that heal, allow the soft tissue to develop to the position that it goes to, and only then come and do it. But I couldn't do it here because I had an emergency. If I left it, that bone disappears. I start to get an infection in the bone gets damaged. So there you can see the fracture line, and you can see what we have here. Now we're able to do gingival reduction. Okay. And this is the nice place to use a laser. A lot of people use blades. The one problem with this tissue is it's like herding cats. If you've worked on this tissue, it kind of moves. As you put the 15th ducks. Okay, then you want to haven't got enough, now try and get it, but you can't. Laser electrosurgery works much better for your gingivectomy. It's more predictable. The problem with electrosurgery is it does not like the plastic. Your laser, which is cooled with less natural heat, works better with these guys. Okay. That will give us our gingival contour, and then the next thing is it'll give us our bone reduction contour. So now we are able to measure every single aspect of what we're doing, put the gum and the bone at the levels that we need as per our design, our facial design that fits in for bone. We then do our summit shield. Once we've got everything, we do our summit shield, we do everything, we put everything in position, we fabricate the crown, everything that is back. put the crown back in. We do our grafting in the socket. Everything goes back with everting sutures. The guy did composite injection. He's never done it in his life. We got from the Madrid Center, they designed the injection molding for him. We took him through, we showed you how to do it, and he got a great result. This guy's jumping up and down. The patient's like, wow. Okay, because look at what we've achieved. We managed to achieve everything in a predictable way. Can polish the stuff. This is an average guy who's now been able to create something extraordinary that he wasn't even thinking, it wasn't even in his consciousness. And he could do it in a predictable way. He got the margins right, everything's right, because everything was pre-planned. So if we've seen it before, we've seen it after, where we've taken the patient to, this is now a brand ambassador, wherever she goes, I don't. That's what I'm looking at. Okay. But most importantly, with the CBCT, can I get this result stable without guidance? Okay, no, unpredictably. It's through the eye of the needle. The bundle bone is still there because we've got the socket shield there holding the bone. Will it hold it over time? Yes. Because this case is already 3 years post-op. We saw, as I said, full arch FP1s, which break my brain, especially when you're not doing soft tissue grafting, you're not doing bone grafting, etc. You're not showing us what the buccal or coronal position of the roots are. There's so much hill coming for us in the future, in my opinion, because of a lot of the FP1s. And this is a guy who came to see me. He owns honey farms and clearly eating his produce. Okay, never mind that. He also manufactures, he has a store and he manufactures stuff that he brings too much of his produce. But you can see with socket shield, with full arch, what we're able to achieve in 5 years. And again, look at the lower anteriors. Look at the attached gingiva, the stability over 5 years of FP1. Again, this has been a game changer for everything that we do. I have to say it is not it is a village. It's not me alone. I work with all of these wonderful people from all around the world. Okay, it's really a privilege to work with them. So my hats off to all of them, especially for research designing. And we are busy writing the plastic extraction book, Shazan and myself and Maurice. It was really fantastic. And with that, I say thank you very much for listening. It's a privilege, it's a growth, and I look forward to the future, and I look forward to doing tonight. Thank you very much. Thank you.